We have this video. So we started this, Dr. Gupta knows it, but Dr. Batra may not be knowing. Dr. Akshay, so we are to start now. All the doctors will come a little late because we have to respect the time and the time of the speakers. So we don't have this, this will come here only. Sorry, the video will not be useful. So let me talk about so we started Indo-European Conference with the help of support of Dr. Alan Crevier in 2008. After that, we started doing regular programs. We did London, Paris, Rome, Amsterdam. We don't have the videos coming here. Following that, we are doing almost yearly programs, small one, not easy, budgets, so many constraints, teamwork. This time, we have a scientific program starting at 10 and finishing at 6 p.m. We'll have sessions related to coronary symposium, then we'll have TAVI, we have Mitra clip, multiple sessions planned. Unfortunately, we don't have the lights, lady, but I will still request Doctor, we can start the session now with Dr. First presentation from Dr. S. Gupta, sir? Okay. Can we have the slide? We'll show the video when the lady will come later on. So the topic, can we have the scientific program copy? I have it. Can we have the distributed, please distribute all the scientific program copy to the people who are sitting here. So the first session will be ECG changes in acute coronary syndrome by Dr. S.K. Gupta. And then there will be Dr. Cardiologist, we have recorded lecture on vulnerable plaque. Then use of drug-coated balloon by Dr. Amit Munjal, who will be talking, he is coming soon. Then we'll talk of thrombosuction, acute MI, then primary angioplasty. And then, of course, it was earlier planned for diabetes mellitus, non-alcoholic liver disease by Dr. C.M. Batra. So we'll have first talk with Dr. S.K. Gupta to start. May I request Dr. S. Gupta is a very senior interventional cardiologist associated with Apollo Hospital. He has more than 35 years of experience, which I know. He was earlier associated with the Railway Hospital, then Batra Hospital, and he's our very important backbone of the Apollo Hospital in number of volume as well as experience-wise. So I'm very happy and glad and really thankful to him that he could find time because he has to go for his OPD. So may I request Dr. S.K. Gupta to start his talk on acute coronary syndrome, which is a very important talk of today. And he will talk about little about ECG and otherwise management. Thank you very much, Doctor. After that, we'll have Dr. C.M. Batra, please.
Good morning. Thank you, Dr. Vivek Gupta, to invite me to deliver this lecture. I'm supposed to talk about acute coronary syndrome and ECG changes. This is the, I thought I must talk to the people about the basic things. हाँ
इसको हाँ उधर शिफ्ट कर दीजिए हाँ इसको हाँ नहीं उधर की तरफ वहाँ पे ऊपर स्टेज पे नहीं आ पाएगा समथिंग बदल है
I think let us start. We have already wasted so much of time. Acute coronary syndrome. What is acute coronary syndrome? What is the definition of the acute coronary syndrome? Acute coronary syndrome is a cardiac condition where patient has chest pain, and it's a spectrum of disease starting from unstable angina, known as ST elevation MI, and ST elevation MI. And the classical symptoms of unstable angina are, or acute coronary syndrome are chest pain. The chest pain may be in the chest, it may be in the, referred to the jaw or left arm, right arm or the back. It is usually associated with nausea, vomiting, shortness of breath and sweating. This slide is very important. Actually, this shows, although everybody knows that patient gets chest pain, but chest pain can vary in situation or in position so much. It can happen in the left side of the chest, it can happen in the center of the chest, it can happen in the neck, base of the neck or in the jaw, or sometimes it can happen in the left arm or right arm, even in the right arm. And sometimes it may not happen in the chest at all, it may be left arm or the right arm or in the back. So all these, the chest pain may vary so much and it can be very confusing. So, but if it is associated with other symptoms like I said, weakness, sweating, ghabrahat, then we should suspect that the patient is having heart pain. Sometimes there can be atypical pain in the acute coronary syndrome in the sense that patient may have only, burning in the chest, or he may have sweating, or he may have weakness, but no chest pain, or feeling of restlessness. If these symptoms are there, sometimes if the situations or the circumstances, evidences are in favor of heart disease, then we should suspect that it can be coronary syndrome. And classically, atypical symptoms happen in either diabetic patients or elderly women or renal failure patients or elderly male patients also. So atypical symptoms usually are associated in different situations like diabetes, elderly people, renal failure, etc. Once the atypical symptoms happen in these situations, one should suspect coronary artery disease. Now, about the diagnosis of the acute coronary syndrome, we have basically two things, one ECG and one TROP-I, enzyme studies. And for diagnosis of ST elevation MI, we have two evidences. There will be ST elevation in the ECG and there will be elevated TROP-I or TROP-T. In non-ST elevation MI, there will be ST depression or T-wave inversion and the enzymes will be elevated. In unstable angina, there will not be elevation of enzyme. There will be only non-specific STT changes in the ECG. This is a very good flow chart. Once the patient comes to the emergency or comes to the doctor's clinic, and you suspect that the patient may be having acute coronary syndrome, the first thing is to do the ECG. If ECG is not showing any changes, then immediately we should try to do TROP-T or TROP-I test. And if the TROP-I is also negative, we should do serial ECGs at the interval of about half an hour. And then one echo can also be done. Sometimes echo may show changes, there may not be changes in the ECG. But if the ECG, 12-lead ECG shows diagnostic changes, if there is a ST segment elevation, or if there is a new onset RBB, or if there is a true posterior MI, then these are the ECG changes which are suggestive of ST elevation MI. If there is no ST elevation, but there are other ECG changes like T wave inversion or ST segment depression, if the TROP-I is elevated, then it is non-ST elevation MI. If TROP-I is normal, then it is unstable angina. In brief, if the patient comes with the chest pain and the ST segment elevation is there, and tropi is increased, patient is having anterior infarction, ST elevation MI. Or if there is no ST elevation, but other T wave or ST changes are there and tropi is elevated, then it is a non-ST elevation. If these changes are not there, but ECG shows non-specific changes, then this is unstable angina. Tropi is very, very important. I will not go into details, but I will just tell about the tropi. This is a very, very important, especially in our hospital, we do high sensitivity tropi test. And it is a very important test to diagnose acute coronary syndrome. It starts rising within 3 hours, after 3 hours or within 3 hours of the heart pain. The peak is there on the second day and it lasts for about a week. So it's a very, very important and for the diagnosis of acute coronary syndrome. Now regarding ECG changes, we have to see 3 things. This is the basic information, and it's a kind of for doctors, this is a kind of going back to the medical student days and see how the ECG changes happens in acute coronary syndrome, and this is a kind of a revision. There is nothing new in this, but as doctors we should remember all those things. There are 3 changes in the ECG: Q wave, ST segment and T wave changes. In acute coronary syndrome, and when there is a ST segment elevation MI, there is appearance of the Q wave and ST segment gets elevated and T wave gets taller. The next slide will show you the classical changes, what happens. Once the myocardium is normal, there are no ECG changes, but if there is a subendocardial ischemia, first thing to happen is tall T wave. If there is a through and through infarct, the muscle get damaged, then there is appearance of the Q wave and ST segment gets elevated. This slide is very important for the basic information. The first thing, when there is no ischemia, the ECG is normal. Within minutes of ischemia, there is tall T wave. First thing to happen is tall T wave. In minutes to hour, the ST segment starts elevating, and you can see, I don't know whether you can see the slide here, the ST segment starts slowly elevating, and finally, if you see, it becomes very high. In hours to days time, the Q wave will appear, and ST segment will be what we call Pardee curve type, and the T wave is flat here. But in a day's time, the Q wave becomes more prominent, ST segment starts coming down, and T wave starts getting inverted. And if you see in days to weeks or months' time, the Q wave will be very prominent and the T wave will become upright. This is another very important slide to have the information. If somebody gets which heart attack is because of which coronary artery disease block, like anterior wall MI, very simple, this is because of the block in the left anterior descending artery, and the changes appear in V1 to V4. There are something called reciprocal changes. With the reciprocal changes will appear in inferior leads. If somebody has inferior wall MI, the changes, the block artery is RCA, and the changes will appear in inferior leads, and the AVL and AV lead 1 will show the reciprocal changes. If somebody has got lateral or true posterior MI, the artery which gets blocked is circumflex artery. ECG changes are usually in lead 1, AVL, V5 and V6, and the reciprocal changes are usually in form of ST depression in V1. In posterior wall MI, there is a block of the posterior descending artery, and here there are no, ECG will not show any indicative changes, but the reciprocal changes may appear in V1 and V2. If there is a block in the septal artery, then we call it a septal infarction. Here there is loss of R wave in V1 to V3. That is the only change, and there are no reciprocal changes. So these, if you remember this, whenever you see the ECG, you can understand that which artery is getting blocked. And as we all know, LAD is the most important artery of the heart, left anterior descending artery. It is supposed to be widowmaker. People call it widowmaker, because if there is a block in left anterior descending artery, proximal part, 50% chances are that patient will die on the spot. 50% chances. Only 50% of the patients are lucky to reach the hospital. 50% of them, when have anti-valve MI because of the block of the anterior descending artery, die at the spot. They don't have chance to see the doctor. Now we will be showing some ECGs, examples of like this. The left upper panel shows high lateral wall infarction, which shows changes in the lead 1 and AVL. The right panel shows anterior septal MI, which shows the ST segment elevation in V1 to V3, and lateral wall MI showing changes in V5 and V6. This is classical example of anterolateral wall MI, where the ST segment elevation in lead 1, AVL, V4 to V6. This is classical example of inferior wall MI, where you can see the ST segment elevation in inferior leads and reciprocal changes in the anterior leads. This is what I was talking about, the proximal LAD block. If you see this ECG, here the ST segment elevation is sky high, very high, and this is a very dangerous kind of a ECG. When we see this, I get really scared of this ECG. And many times the patient has got very bad outcome once you see this ECG. Such a patient, if comes to the emergency, has to be rushed to the cath lab immediately, do angiogram, open the artery. Chances of survival are very good. Another important information about ischemia is in presence of LBB. Once there is LBB or patient is having pacemaker, having LBB because of the pacemaker, then it becomes very difficult to diagnose infarction, but there are certain criteria to diagnose infarction in presence of LBB. Like this slide shows, if there is a J-point depression, unusual J-point depression in lead 1 or AVL, then you can suspect acute coronary syndrome. Or there is unusual J-point elevation in lead V1, V2, then also you can suspect acute coronary syndrome. This next slide shows, this is called Garboza criteria for diagnosing acute MI in presence of LBB. Here he has given 3 criteria. One is in those lead 1 or AVL, if there is a J-point elevation of about 2 millimeter, you can suspect acute coronary syndrome. Or if there is a J-point elevation in V1 of 5 millimeter or more, then you can suspect acute coronary syndrome. Similarly, if V5, V6, V1, V2, if you see J-point depression of more than 2 millimeter, you can suspect acute coronary syndrome. So this is many times, when we have practical problem in emergency and patient has ECG changes suggestive of LBB and symptoms of chest pain. So these criteria are going to be very helpful. We can diagnose acute coronary syndrome and do the TROP-I, do the echo, you will have the information and you can treat the patient immediately. This is what the ECG, classical ECG shows LBB, and if you see the V3, here there is a J-point depression of about 5 millimeter, more than 5 millimeters. So there is a very strong suspicion that this patient will have acute coronary syndrome, acute MI. Then once you suspect acute coronary syndrome patient, we have to stratify, risk stratify, how much risk the patient is having. These are the 7 criteria here. Like age of the patient, if age is elderly, more than 65 years of old, if there are 2 to 3 risk factors, if there is a documented CAD before, if there is ST segment deviation, if patient is having pain for more than 24 hours, or patient is using aspirin before, or there is elevation of the cardiac enzymes, then if you take these 7 criteria, then you can risk stratify patient into 3 categories. If there is 1 or 2, if there are up to 2 risk factors, then it's a low risk. If there are 3 to 4, intermediate risk, and 5 to 7, high risk. Those patients who are having intermediate risk or high risk, they need immediate care and immediate treatment. So, for the diagnosis of acute coronary syndrome, the basic, these are the very basic things. We have to suspect the acute coronary syndrome, take a good history, do a good physical examination, take a ECG and do cardiac enzymes, and risk stratify the patient. If patient comes into the immediate high risk category or middle category patients, then these patients require immediate treatment. They should be referred to the cardiologist. They should be referred to the big hospital. Immediate angiography should be done, and angioplasty, if possible, should be done. That may be life-saving. You can save so many patients. Thank you very much. I'll be happy to answer any questions if there.
Thank you, Dr. S.K. Gupta, for a very nice talk. Any question we can have a quick answer to?